We are here to talk about Take a Step, PAD and PVD, common issues that most women might often overlook. So, how many times have we ignored something about ourselves because we were so busy taking care of everybody else? This morning, I almost walked out without brushing my teeth because I was rushing my kid to t-ball practice. So, I get it. So, we're not going to overlook those things today. We are going to prioritize ourselves and our heart health. And so, PAD and PVD, I'm going to let them explain what that actually means. These are conditions that might limit healthy blood flow to both your arms and your legs, often causing pain, numbness, and slow healing wounds. They're frequently underdiagnosed, especially in people with diabetes and heart disease. Raising awareness is a key step towards prevention and early treatment. So today we are joined by our experts, Dr. Hughston and Dr. Marina Iskandir. Dr. Hughston is a board-certified cardiologist with advanced training in imaging and heart diagnostics. She earned her medical degree from Texas Tech University Health Science Center and completed her internal medicine residency and cardiology fellowship at the University of Texas Health Science Center in San Antonio. That's where she also served as Chief Cardiology Fellow. A Lubbock native, she is committed to caring for West Texas communities and staying up to date on the latest treatments so her patients can live longer, healthier lives. When my hair was blonder, we also were often mistaken for twins. I could only take that as a compliment, by the way. Dr. Iskandir now is a board-certified cardiologist and interventional cardiology specialist with 7 years of experience caring for patients with complex heart and vascular conditions. After completing her training at Texas Tech University Health Sciences Center, she served as an assistant professor before joining Covenant Medical Group to continue caring for Lubbock community. Dr. Iskandir is passionate about advancing heart care, especially for women, through compassionate, innovative, and evidence-based treatment. All right, ladies, we're gonna start with the difference between arteries and veins. Take it away.
So, peripheral arterial disease and venous disease, it sounds the same, but the two elements do have different jobs. I will be talking about arteries, and Dr. Hughston will be talking about veins. And just to kind of the quick anatomy lesson, the arteries are responsible for bringing blood from the heart full of nice oxygen down to our extremities, our arms and legs. They're very thick, elastic, and very strong. Veins are responsible for bringing blood from our feet, hands, all our organs back to our heart, and veins are a little bit on the flimsier side. However, we're going to focus on arteries first. So, peripheral arterial disease is the disease process is when you get narrowing of the vessel itself. It can involve your aorta, which is the main blood vessel in the abdomen, and it splits off to two arteries, the iliacs down to your feet, where you have a series of different arteries they get smaller and smaller as they get to your organ, down to your hands and feet. Blockage can occur at any level. And that is mostly composed of plaque, and that plaque is full of cholesterol and other inflammatory markers. What peripheral arterial disease symptoms, so most common symptoms, and I think there are some other symptoms that women may experience differently or report differently, and that's going to be bilateral, so both legs often will feel tired, weak, and depends on which stage you are in the disease process. It can feel like severe cramping and pain when you walk. That's what claudication is. Pain when you walk. You normally can walk around the grocery store in one loop, and lately you have been stopping more frequently because your legs get cramped and tired. You rest, feel better, and you keep moving. That's claudication. Cold and numbness of both of your feet. If you have a sore or you cut your nail and you have a hangnail that you cut and in that it's not getting better after 1 or 2 weeks, that can indicate underlying peripheral vascular disease or peripheral arterial disease. You can also get skin discolorations, purple, blue in more advanced cases that don't go away. Women tend to feel the aches in their calves, but also could be in hips and thighs. And that just it's difficult to differentiate from other disease processes, and a lot of patients are asymptomatic altogether. So what are the risk factors for peripheral arterial disease? It's going to be smoking, then diabetes. Okay? Those are my everyday patients that have the severe, advanced versions of the peripheral arterial disease, and we have to get creative in treatment. But those are the two biggest risk factors. High blood pressure, high cholesterol, age, and family history, absolutely contributing factors. Again, all of these risk factors also go to heart disease. It's the same disease process for the heart as it is for the legs, the arterial system. Women specific is menopause and estrogen loss, if you've had high-risk pregnancies or peripartum or preeclampsia, increased risk of vascular disease. Diagnosing is simple. It's a ABI test is the first screening test. I think everyone who has risk factors for cardiovascular disease should at least get an ABI, which is basically, we were doing some of that up at the front where we're measuring your pressure in your arm and your leg, and we get a certain ratio. And based on that ratio, it can give us an idea of where you are in terms of any vascular disease. If the ABI is abnormal, then you should probably be in with a vascular specialist and go through all of the subsequent studies to make the diagnosis. Treatment options, lifestyle. Actually, peripheral arterial disease, just like we had mentioned, the other one, conditioning your heart and conditioning your legs are also very similar. Even if you have blockage, going in and exercising regularly in short increments and increasing slowly every week how much you push yourself in terms of walking through that pain can actually promote improvement of blood flow to your feet without any invasive therapies. Obviously, quit smoking, diet, and just pay attention to your feet. Medications and procedures, yes, we do have some options, but if we can manage with lifestyle that is superior, medications and procedures, they are limited. They're not cures. They are options to help you just live better, but not cures. So prevention, I think very much of what Dr. Cochran mentioned before in terms of diet very much falls under these what to do to prevent peripheral arterial disease and vascular disease in general. And taking a look at your feet. Look at your feet every day. Look at your sores. If you have anything that hasn't healed in 1 to 2 weeks, you should definitely be checked out for peripheral arterial disease. At least do some you should get tested. I'm gonna shoot it over to Dr. Hughston.
Okay. Can you all hear me? Okay. So we're gonna switch gears now and no. Thank you. Okay, sorry. So now we're gonna switch and talk about peripheral venous disease. So thank you, Dr. Iskandir, for talking about the arterial side. So just kind of to recap, your veins are what drain the blood back to your heart. So the oxygen, the organs and the tissues have already sucked out the oxygen, so this is deoxygenated blood. We have superficial and deep veins throughout our body. So the superficial veins are draining the skin, and then the deep veins are actually buried underneath muscle. So you can't see the deep veins now. We can see superficial veins in certain people, and we'll talk about different pathologies that if you have like varicose veins, is what I'm kind of getting at. So how do veins work? If you look at the picture of the 2 feet, the one on the left is showing you a healthy vein. So we have valves within our vein. They're one-way valves, and they close to prevent blood flow from flowing backwards down to the feet. And so when we're walking and our calves and our thighs are contracting, that's helping push that blood flow back out of our legs and into our belly and then into our heart. Now, if you have superficial venous insufficiency, where your veins are getting dilated or big, those valves, they don't meet in the middle like they used to. And so you get a backflow of blood down into the foot, and then you can get complications like varicose veins or spider veins, which we're all pretty familiar with. So these are some different examples of things. There is your reticular veins or your spider veins. Varicose veins are when those veins get really dilated. You can also have something called corona phlebiectasia, which is when you have this kind of, they're small, they're little red, and they kind of look like a little crown around your ankle area. And again, these are your superficial veins. These are not deep veins. Sorry, hold on. There we go. So signs and symptoms, heaviness in the legs, swelling that is worse later in the day. You can feel like your skin is tight or itchy. You can also have skin discoloration where your ankles or your feet will turn kind of this like bluish, purplish color. And that's actually because blood is pooling down there and it changes the color of your skin. So what are the causes? Because in a lot of things in medicine, if we can figure out what's causing it, we can we go through that to try to treat it. The biggest thing is elevated central pressures, and that mostly comes down to abdominal obesity. If you think about a pregnant woman who's really far along in her pregnancy, like 39, 40 weeks, and she's complaining about swelling in her legs because she's got a big baby sitting in her belly that's pushing on the veins in your pelvis and in her IVC, which is draining all that blood back to the heart. Well, it's the same thing if we have a lot of abdominal fat that's pushing on those veins, because veins, they're thin-walled. There's not a muscle around it like for arteries, and so they collapse when there's too much pressure sitting on top of it. So a lot of times, trying to lose abdominal weight, which, as Dr. Cochran talked about, becomes an issue for women perimenopause and postmenopause, will help relieve that pressure down in your legs. Obstructive sleep apnea causes high pressures in the right side of the heart, and that can then back up into your veins and your legs. Volume overload, which I say this with a caveat because a lot of times people think, well, if I just take diuretics, it's going to go away. That's not always the case, and sometimes we can cause kidney injury if we give them in excess. Compromised pump function. So if you're wheelchair bound or you're mostly sitting around and you're not exercising, you're losing that pumping function of the calves and the thighs, pushing that blood out. Lymphatic dysfunction, so lymphedema is, we're not really going to go into this whole other topic, but lymphedema is another big problem as well. Obstruction from prior DVTs or blood clots in the veins or May-Thurner syndrome, that can also compromise the blood flow back. And that's more common in women also in older age. And we'll talk about that more specifically. Okay, so how do we diagnose this? The first step is a venous Doppler, which is just an ultrasound of your leg, and we kind of run it up and down the leg with gel, and we look at the veins, and we measure the reflux, or the time that the blood is flowing backwards. And that's just an image you can see where in between those blue bars is the backwards flow, and we're just measuring the time. And we have different cutoffs depending on the vein on what's considered abnormal. We can also look for blood clots. We can measure how dilated the vein is. The thing to know is that sometimes you can have a lot of reflux in a vein but not have a lot of symptoms. And so it can kind of get a little tricky when you're looking at treatment, and we'll talk about that in just a bit. So treatment. First, like we talked about, reducing the central venous pressure. So that goes with getting down the abdominal weight, treating obstructive sleep apnea if it's present. Diuretics can help for some patients, but we have to be careful because we can really make the kidneys mad if we give diuretics and there's no fluid to take off. We're essentially just dehydrating you. Compression therapy, like compression stockings or the dynamic compression, which is actually like a big Velcro thing you put on your legs and it squeezes your legs to help push that fluid up. That is kind of the cornerstone of treatment. You can buy compression stockings online on like Amazon. There's also prescription grade compression stockings, and they can have zippers, because really compression stockings are hard to put on and take off. The ones with zippers tend to be easier for patients to do, so you can talk to your doctor about that. Leg elevation is also huge. So when you're, sitting or watching TV, you elevating your legs, and like it's not just like here. We're talking like up to the level of the heart to really get gravity to help that fluid come out. Exercising your calf and your foot flexion. So even if you're, have bad arthritis, it's hard to get around, just doing things like circling your feet like out and then in, or if you just pretend that you're picking a piece of paper off the ground and you're when you spread your toes and squeeze like that, you're flexing your calf muscle, so that can help as well. There are some supplements that you can also get over the counter. These are not regulated by the FDA. The trials, like the evidence behind it is kind of like meh. It may help, it may not. But the micronized purified flavonoid fraction, or MPFF, is the one that's the most well studied. Okay, and then procedures. So when do you take the next step from just like your lifestyle things to, should I have a procedure to try to get to help with my veins? And we're talking mostly about your varicose veins, that sort of thing. If you have a venous ulcer where you have so much fluid down here in your calves that the body is trying to find a way to escape, and you're breaking open these little ulcers, or sometimes they get really big ulcers on your legs, that's a very good indication to go and get ablations or sclerotherapy to help get that ulcer to heal. If your symptoms and your image correlates, like that Doppler I talked about, if you're having symptoms in one area, like a varicose vein here, and it shows that there's severe reflux in that area, that would be a reason to go ahead and do an ablation or sclerotherapy. Sometimes just cosmetic reasons. I don't want to speak for everybody, but like we take care of our hair and our skin, and we spend all this money doing that. There's no reason why you need to walk around with spider veins and varicose veins if you don't want to. Now, a lot of times if it's cosmetic reasons, of course, that's more expensive. It's an out-of-pocket expense. But there are ways we can try to get it covered by insurance. There's two different ways to go about doing this. There's thermal treatment, like ablation is one of them. You can do radiofrequency versus thermal ablation. And you're actually taking a catheter and you're going up into the vein and you're burning the vein. So you have to give medication to help with pain, and that makes the vein scar shut. And so the vein becomes from bigger to smaller. Sclerotherapy is another way of doing it, where you actually inject a chemical. And again, it's causing an inflammatory reaction which scars the vein shut. Now that treats that vein in one area. Again, it's not a cure. You can have other varicose veins that pop up other places if we don't address those other things like abdominal obesity, exercising or using your muscles to move the fluid out. Now, I will say there are women who, this is none of them, they don't have abdominal obesity, they are active, and it's just bad luck, and it's just genetics, and it's just like, your mom had it and you're gonna have it too. So that's also something which is just something we can hopefully help with procedures and things like that. So deep veins, now we're talking about the muscle, the veins underneath the muscle. So May-Thurner syndrome is a issue where your iliac vein is being compressed or pinched between your iliac artery and the vertebrae. And you can kind of see a representation of that. That happens more often in women, scoliosis, if you have dehydration or past radiation. How do we diagnose this with an ultrasound or a CT? And the way that we go around fixing that is with stenting to help relieve that backfill of pressure, and it can help with a lot of swelling in the leg. And then finally, post-thrombotic syndrome. So this is what we're talking about with DVTs, which stand for deep venous thrombus. Now you can also have blood clots in the superficial veins, but specifically you can see on the left that black kind of circle thing there. That's a vein, and that's blood in the vein. And then on the right, you can see where there's kind of that cloud-looking thing. That is a blood clot. And you can see how the blood clot is taking up a big chunk of the vein so that it's obstructing the blood flow. And so you can get swelling and pain and skin discoloration downstream from that. We do use blood thinners to try to eventually make the blood clot go away. If the symptoms are severe, where you're having problems with ulceration or skin changes, you can try to go out and clean out that clot. And that is all of the information I have. Do y'all have any questions?
We do have a couple, and so if we could get our other experts back up here, I'm going to give you guys a couple of takeaways. First of all, if y'all couldn't see all of the movements that Dr. Hughston was doing, she was very active over here in her chair. We also actually have a handout for y'all that you can grab outside this room that has all of those exercises on it if you can't remember all of Haley's choreography. But a couple of takeaways from this talk is what Dr. Iskandir wants us to know is that PAD is a warning sign. It means your heart, brain vessels may also be at risk. And so this is a whole body issue. Lifestyle changes, especially, what did she say? No smoking. And getting regular exercise are the most powerful treatments available. And if you have a foot wound that isn't healing, leg pain at rest, or sudden color changes, please seek care immediately. Now, from Dr. Hughston's talk, what we need to remember is that we need to treat the cause of venous disease and not just jumping straight to procedures. Compression socks, elevation, and exercise are going to be the cornerstones of our treatment, but if those don't work, we do have other options. So, ladies, we have some questions for you. Number one, if I have a family history of heart disease, how often should I screen for any of these heart diseases?
So first of all, you should be seeing a primary care doctor at least once a year, because everything starts with them. They're the ones who are screening for high blood pressure, high cholesterol, diabetes, and also cancer screenings as well. And then if you tell them their family history and they think that we need to take a closer look, they will send you our way, and then we can do more advanced testing. So I hope that answers your question.
I was going to add just a little bit to that. So family, and the other thing is about family history, right? I think it's a very important point to differentiate between family history and we live and eat and do the same thing. So family history, in terms of saying premature coronary artery disease, is going to be, usually the traditional thing is we say, immediate family members, so parents or siblings who've had an event before the age of 55 is basically, that's premature heart disease. Those are the patients that we're trying to catch in their 20s and 30s and kind of intervening. Now, if we all live the same way in terms of eating habits or smoking or, sedentary lifestyle, that is more of a, community thing. So it doesn't mean it's family history. It's again back to lifestyle, which is I think what we've been harping on really this week. The lifestyle and the prevention at home and what we do in terms of eating and moving is going to be most important.
What are some proactive screenings and exams that help identify clogged arteries? Can you go more in depth?
So yeah, there are some really good ones. One that we use a lot is something called the calcium score. So a calcium score is a CT scan of your chest. It is low-dose radiation. There is no contrast that's used. And what we're looking for is calcified plaque or cholesterol buildup. And if your calcium score is 0, your risk of having a heart attack or a stroke is low over the next 1 to 2 years-ish or so. But if it's 1 or more, then you're laying down plaque in your vessels. And that can help us know how aggressive do we need to be. Do you need to be on aspirin? We need to start getting that cholesterol down? It just helps us have more talks about maybe patients that were on the border of do we need to pull the trigger and start all these medications versus no, let's focus more on lifestyle, and we can kind of keep monitoring. The other thing is lipoprotein A, which is outside your normal cholesterol panel and is recommended that you screen at least once. Lipoprotein A is a stickier cholesterol, and it's also thought to be more not as heavily influenced by your diet, and so needs more it would be a reason to start medications sooner. So those are the two things. One thing to say about calcium scores, insurance, nobody's insurance pays for it, okay? At Covenant, you can get a calcium score for $125. We don't do them annually. Right now, the guidelines say every 3 to 5 years, and sometimes if it was if your calcium score was to be high, I would never check it again because it's not gonna change how I treat you.
Side note, shameless plug, I'm reading it word for word. I started Covenant's cardiac rehab, and it's wonderful. So thank you to whoever you are who is saying that. All right, question 3. What are your thoughts about jumping on a rebounder for lymphatic draining?
With some of the lymphatic treatments out there, just because we really don't see it, and the places that do them, they're very kind of niche and like sub specialists, and mostly I think vascular surgery too sometimes we'll see it more.
Yeah, I would agree with that. I think it's a lot more wound care as well. They help with lymphedema as well. So I'm sorry, I wish I knew more about it.
Shannon's shaking her head back there. When we say rebounder, do we mean like a vibration plate? Is that what they're kind of saying? Or is that a whole different thing? Oh, a trampoline. Thank you. Okay. All right.
Oh, like the little shaker and the kind of. Oh, okay. Yeah. Yes. Okay. So so lymphatic, I guess we're thinking lymphatic disease. Like I'm thinking, like patients who have cancer and other things, but kind of just on the basis of even like venous disease. Yeah, actually, I have some patients who love it. They will say it really helps kind of move in terms of if it was like venous, pooling and insufficiency that it helps a lot with that. I do find, so that's something that it helps, but whether it's data-based or we actually have anything to say that, oh, this is something that we'd recommend, no, I can't say that.
Let me ask you guys real quick. This is an off-the-wall question. Like the placebo effect, I have like a shake plate that I get up with in the morning. I don't know if it actually does anything. It may do absolutely nothing, but if it makes me feel better, what is the benefit of just at least mentally tricking yourself into thinking some of these things work? Don't laugh. I heard y'all laughing, but like the brain is a powerful tool, So if you convince yourself that it's working, then does it work?
I think everyone's different, and I think that sometimes, especially on these things that there's no real like clinical data behind, but if it helps you, then keep doing. It's like those some of the non-FDA approved things for venous disease that I talked about. If it helps, then use it, and if it doesn't, don't waste your money on it.
Y'all can laugh at me. It's okay. I just wanted to know. I also have questions. All right, question 4 from the audience. Let's explain the difference in wearing socks, support hose, or compression stockings for leg pain.
This is the problem. So arteries and veins, they, are essentially doing the same job, but their treatments are different. So with vein, we want your leg elevated above your heart. If it's arterial disease, your symptoms will be worse because you have blockage, and the flow is your body's fighting harder to do that. So if you have more of a swelling problem and your sores are more on your calf or on your shin, that's going to be more venous disease. That's going to be more of compression socks and elevation. If your legs really don't swell, but they're very painful when you're walking, no, we don't recommend compression socks for that. So that was a really good question to distinct between the two disease processes. Yes, it is different in terms of that management. But for both, walking helps. So walking in terms of calf muscles to help your vein, but also in arterial disease with walking, when you push through the pain, and I know it sounds odd, and that's what the supervised exercise program is basically you go on a treadmill in rehab and they tell you, oh, I have pain, I'm going to stop, and they tell you, no, keep going. And that promotes building new detours and pathways around those blockages. Our bodies are very smart, they're very resilient, and have self-healing options. And if you build enough collaterals, then we won't have to go down the rabbit hole of procedures and treatment. Because I will tell you, peripheral arterial disease, I can open a vessel, but 6 to 8 months later, if you continue to smoke or don't do any of what you're supposed to do, it will close again. And we will try and open it again. And then you get kidney failure. And it becomes this really, it starts just spiraling out of control. And some people end up losing their feet, legs, and that's kind of where amputations come in with with patients who have advanced peripheral arterial disease.
And if we're talking about compression stockings for veins, so like if you're having more of a problem with swelling, the magic number is around 30 millimeters of mercury when you're looking for your compression stockings, 20 to 30. And if you buy, you go on, if you order them or whatever, it'll tell you how much support, how much pressure it's giving you. If you buy them, you gotta replace them. You know what I mean? Like they will eventually stretch out, so you do need to be kind of aware of that and buying new ones every 3 to 6 months, just depending. Okay.
Okay. Do you have to see a cardiologist to get a venous Doppler?
You don't have to. Any provider or physician can order a Doppler, and then if it's abnormal, be referred to someone who can, start doing the process of, if we're talking the procedural route. But no, you don't have to see a cardiologist.
Okay. This is going to be our last question, but I had a procedure for PAD many years ago, and it involved radio waves. Is there a non-thermal method now?
Yes, so there is something called sclerotherapy, which is when we inject a chemical, and it does it causes sclerosis, which is like it causes an inflammatory reaction that makes the vessel kind of seal shut. It's not the thermal ablations can be painful. This one is not. I'm not saying it's not painful at all, but it's not nearly as painful as thermal ablations.
Dr. Hughston talked about ABIs, we've talked about blood pressures. All of those checks are happening over in room B. So after these talks today, if that's something that you want to maybe check out, go and speak to our experts and they can see if you qualify for screening. We also have some other things over there like body composition and other tests. So I want to say thank you to Dr. Iskandir and Dr. Hughston for their insight today. Can we get a round of applause for our doctors, please? We are going to take a short break, and we will be back here for our last session, Breathe Easy, with Dr. Turnbow and Dr. Solis.